Good afternoon, everyone, and welcome to the Recovery Science Echo brought to you by Bevel, Texas, and the Center for Substance Use Training and Telementoring, CSTAT. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, email, and affiliation into the chat. To access the chat feature, please click on the speech bubble icon at the bottom of your window. To all the Bevel Texas providers, please make sure you identify yourselves during the session by entering your information into the chat, or if you're joining via phone, please email your name and phone number to beveltx@ithaca.edu. We encourage everyone to join by video for the discussion portion of the session. That said, regardless of how you've shown up today, we're just happy you're here to learn alongside us. We are recording these sessions for later distribution through the Bevel YouTube Texas channel. Any info you put in the chat will not be shared in the recordings. Please stay muted unless you're speaking, and we do encourage you to speak. If you join by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6. You can also use the chat to share your comments and questions. There are a lot of us in this space, so please keep your comments brief to allow others to a chance to share and speak up as well. And finally, please note that no predicted health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, birth dates, or any screening dates. Anything that can identify an individual is not allowed in the session. Towards the end of the session, our wonderful IT support, Karen, will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to define and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on a recovery-informed theory using subjectivity to inform science, and will be presented by Dr. Austin Brown. Following that, we will discuss a case presented by Dr. Robert Ashford. We will start with some introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you all again for joining us today. These sessions are what we make of them. We encourage you all to share your perspectives and insights in today's conversation. And with that, we will do some introductions. Robert.
Thank you. It's a delight to always get to go first. Appreciate that. Good afternoon, everybody. Happy New Year. If I haven't spoken to you on another Zoom or in person somewhere else, my name is Robert Ashford, person in recovery, and also a hub member and one of the co-Is on the Peer Recovery Innovation Network, which is one of the 9.R24s that helps support this ECHO, along with many others who you get to hear from, but glad you're all here.
Thank you so much. Sierra.
Hello, I'm Sierra Castedo de Martel. I'm one of the hub members. I'm a postdoctoral fellow at Chestnut Health Systems, working on the CHEAP initiative, and I'm coming to you from Detroit, Michigan.
Thank you so much for joining us. Emily.
Hi, I'm Emily Hennessy. I'm Associate Director of Biostatistics at the Recovery Research Institute in Boston, although I'm currently coming to you from the airport. So nice to be here.
Well, thank you for joining us. Cheryl.
Hi, everybody. Thanks for being here. Cheryl Pacapelli, Project Director for the Facilitating Organization for Peer Recovery Support Services in New Hampshire, which is just a big name for overseeing a statewide network of recovery community organizations.
Well, thank you so much for joining us today. Adrian Lindsay.
Hi, everyone. I'll keep it brief. Adrienne Lindsay, I direct our Center for Substance Use Training and Telementoring, which oversees our ECHO programs here at Bewell, Texas at UTL. Thanks. Thanks for being here.
Thank you so much. Julie Parrish.
Hi, everyone. Julie Parrish, ECHO Program Manager here at CSTAT. Thanks so much for being here, everyone.
Thank you. Daniela.
Hi, all. I'm Daniela. I'm the Project Manager for FRIEND, and good to see you all.
Thank you so much. And with that, we will move on. To Dr. Brown.
I'm Dr. Austin McNeil Brown. I am a recovery scientist. I'm coming to you from Gråsten, Denmark.
Thank you so much for joining us. And we will get started with our didactics in that case. Dr. Brown, you can take it away whenever you're ready.
Okay, can everybody hear me?
Yes.
Okay. All right, so the title of this presentation is Recovery Informed Theory, and in particular, using subjectivity to inform science. A brief disclosure, I don't have any financial interests other than I serve on the external advisory board, and I receive a small stipend for that. And of course, the views and opinions are my own and not necessarily those of UT Health. So there are three outcomes that I'm hoping to achieve here, which the first is to learn why recovery science needs a grand theory. The second is to understand methods and utilization of subjective experiential knowledge in creating objective science. So how do we turn experience into objective measures? And the final is to orient attendants to the use of recovery-informed theory in the day-to-day science and practice, and to give those in attendance, kind of a head start in some places where they might begin to apply these ideas. So I was trying to think of a good example to come up with that was not related to anything in psychology. But we start with kind of the fundamental question of what constitutes certain experiences and how are those experiences captured by scientists and then turned into things like metrics, definitions, testable theories, data that proves efficacy or effectiveness. So if we take something like a little girl who goes fishing with her father regularly as the kind of experience, and let's say for whatever reason, as scientists, we decide that we want to measure this experience. So where might we begin with this? So the question becomes, what designates a positive or a negative fishing trip? Psychologically speaking, numerically speaking, qualitatively speaking, quantitatively speaking. So what are some of the measures that we might come up with? Well, we might say, well, how many fish did you catch? And if you caught a certain amount of fish, then that is a quote unquote a good trip or a positive fishing trip. Or we might say, well, you spent several hours with your father on a boat catching fish, and that's time spent with your dad, and that's a generally positive thing. So X amount of hours is a good trip. The problem with this kind of measurement is that it imposes a certain idea of what is and is not valuable in any given experience, right? And anybody who's been fishing with their dad can tell you that it's a lot more. There's a lot more to it than just how many fish you catch, how many hours you spend out there, right? It's a whole experience that has all of these kind of affective and experiential ties that ultimately make it perceived to be a good experience for the people who were there. And so we see that these measures, these types of measures, like how many fish or how many hours, these might totally miss the point of like what it means to go fishing with dad, right? Which is something that is very meaningful. And then I think the final question, I think this is probably more attenuated to the current science, is who benefits or is given empirical authority when certain when certain things are deemed as effective. So certain kinds of treatment, certain kinds of medication, certain kinds of this, certain kinds of that. There's always a net gain for somebody and a net loss. So something's always lost and something's always gained whenever you decide to reduce something down to any sort of observable metrics or measurements. And so it's important about being cognizant of this fact when we talk about something that's experientially based, like recovery. So Thomas Kuhn wrote a book on scientific revolutions, and I think point 3 or 4 in his discussion was that when anomalies undermine some sort of existing paradigm in a scientific field, that a new paradigm can be proposed, and that if it gains acceptance, it replaces the old one. And so, in recent years, and I would say in probably the last decade or so, really what we began to see was that addiction science had really defined and measured recovery, and that was not necessarily capturing what it meant to be in recovery or for someone to recover. So the crisis here is that we have this debate about what is considered valid or quote unquote real recovery, right? Because there's a lot of debates within recovery as well. And that separating out addiction science, so the measure of pathology, the treatment of pathology, the defining of pathology from recovery, which is an experience of growth and healing, which are not the same. And so the central crisis here really came out of my own experience in studying my clinical training, where I would read all these manuals and definitions, and I would say, well, that's partially true in my own experience, or that was, that's partially valid at some stage in my own recovery, but none of it was very comprehensive, and none of it really matched any of my own experience. And so what occurred to me was that what was really going on here is that we had a bunch of people that were imposing upon recovery what their own ideas of recovery and what they might be, and then trying to measure them scientifically. Whereas someone in recovery like myself is like, well, if you would have asked, I could have told you that this measure or this is not relevant, but this is, and so on and so forth. So we need a grand theory that's going to guide any sort of separation from addiction science, and that's kind of where we began. Grand theories can help to inform. They're not hypothesis-driven theories. They're basically frameworks to outline an entire field, and they help to inform the types of questions and the mid-level theories that come out underneath that in that field that can then be tested. So addiction is the study of pathology, like I've mentioned. It's not necessarily the study of healing. And recovery is a highly relational process. So it's about the individual and the people around them and the institutions, ideas and behaviors that they engage in. And so there's this entire matrices of relationships that are around the person who's in recovery that weren't even being touched by any of the existing measures in the field. So one of the things we came up with was this idea of recovery informed theory. And so this and positing this as a grand theory for recovery science. So being the overarching theoretical framework that should inform all of the mid-range theories. So the theory is really simple. It's that successful long-term recovery is self-evident and is composed of a fundamentally emancipatory set of processes. And so from that, we can begin to build out a meaningful set of theories and measures that can tell us what this thing recovery is and how to predict it and how to measure it and how to define it. So it's self-evident in the fact that the difference between the state of addiction and the state of recovery are obvious. And they're not only obvious to the individual, but they're obvious to the people around the individual and in their relationships to the world. And an emancipatory set of process really means processes that are composed of all of these different elements that either facilitate or help to create the conditions under which a fundamental movement from the kind of bondage of pathology into the freedom of wellness, right? So you go from having a restricted state that's defined by substance use disorders and all of the stuff that goes along with that, to this freedom of wellness, where you are no longer subject to this type of restrictive lifestyle or behaviors. So my team at Kennesaw State University at the time, along with Dr. Ashford, really helped us to kind of take this idea and flesh it out. If we consider, if we place recovery informed theory central as recovery science, then we have a new paradigm, which basically allows us to inform the science and research, as well as the programming and practices, and education and prevention. So if we consider the programming and practices, for example, then it's this idea that we can capitalize on these kind of common subjective occurrences that occur in aggregate recovery experience. So the bulk of recovery experience in a qualitative way denotes certain elements that we can then capitalize on in order to facilitate whatever institutions, programmings, or therapeutics we need to help foster this growth. And we can also do the same thing. We can expand it out into policy. We can expand it out into education. We can expand it out into prevention, where we basically say, okay, well, what is the recovery experience and what can it tell us about prevention? What can people in recovery tell us would have been meaningful on the end of prevention? What can they tell us would be important in the realm of policy, right? So it's not just science. It's not just the science and the measurement of recovery that can be improved with recovery informed theory. This is a quote from our paper. It basically says a lot of the same thing. Ultimately, though, what we're talking about is efficacious systems. Most of us work in systems. Most of us work in some sort of capacity that butts up against substance use disorders and then tries to hopefully create some level of change for individuals and communities that is going to move them towards some level of health. And so what we really have to do is take recovery phenomena and use it to inform those systems that we work in, to increase their efficacy and their responsiveness, and to create the effectiveness of whatever interventions we're using. And so where do we begin? We begin with the phenomenological lens and kind of general collaborative inquiry. If you have a social work background like I do, you know what collaborative inquiry is, right? It's how we co-construct things with both problems and solutions with clients. And it starts from a place of really asking people what's going on with them and how do they talk about and think about the things that are going on in their lives. And we can look for and then try to replicate these major commonalities that we see in successful recovery trajectories that keep popping up in the aggregate kind of experiential realm, so that we can understand recovery as it occurs in situ, and that means as placed. So one of the ways to think about this is that why do we need to study and understand recovery the way that it's placed out in the world and the way that it happens in situ is because it exists completely independently of science. medicine or psychological care. So recovery has existed well outside of the clinical space and continues to exist out there. And people get better all the time with and without any sort of help. And so we have this kind of standalone thing out there that we need to figure out how to measure and how to take that experience and use it in the places where we are that are related to science, medicine, and psychological care. And also, you know, half of the people who would qualify for being in recovery, you know, it's a little less than half. They don't even identify as being in recovery. So we're talking about people that both identify as being in recovery and then see themselves as somebody who engages in some sort of trajectory of growth that moves them towards health. This can settle a lot of the debates that we've had, I think, about what we're talking about here. You know, it used to be that we would just measure things as like days abstinent or percent less using days, right? Like that's essentially how addiction science had qualified and quantified recovery. And so if we just begin with the idea that recovery is really the central idea here and it exists outside of whatever we say about it, then we take upon ourselves a new responsibility to go out and look for it and understand it in a way that's organic to the experience. Doctors and scientists have never been the authority on recovery, and that's always kind of humbling to think about. And then we have to consider the fact that outsider knowledge, definitions, and metrics are an imposition upon the individuals and communities that we're trying to study. And this is really important, and it's something that was overlooked for a really long time, with addiction scientists coming in and say, okay, well, how many days have you been abstinent? Okay, well, treatment X produces X amount of abstinent days, and that's quote unquote superior to something else, right? Which doesn't make a lot of sense because anybody in recovery will tell you it's a lot more than that. And expertise in addiction science does not automatically equate to expertise in recovery science. This is also something that I think is really important to consider. And, you know, kind of the takeaway here is really that the bulk of recovery occurs outside of clinical practices, outside of science, outside of medicine. And these are institutional orthodoxies that if we want to study recovery, we're going to have to figure out how to do it without imposing those institutional orthodoxies on individuals, on their communities, on their culture and history of those communities and the recovery organizations and institutions which facilitate. So, how do we, you know, well, okay, that's great. Well, where do we begin? You know, let's just, one of the things that I tell people to consider is let's just bracket, just as a thought experiment, just bracket everything that you think you know about recovery. You know, 12 steps, medicine, policy, all of that. Just put brackets around it. And then ask yourself, well, what is this thing? If I don't impose these things that I already have prefigured in my mind upon this situation, then what is really going on? And from that, we would see that there are certain systems, ideas, institutions, and events that people in recovery point to as things which made the difference in their healing or not healing, and that there are major phenomenological differences in between any type or genus of recovery trajectories. And we can understand better how these different trajectories both meet or avoid individual needs, desires, and hopes. So just kind of a pro tip here on my last slide. Really, this is what we're talking about is communities, and we're talking about people with certain identities. And so whether we're talking about this in a sense of like indigenous methods or some other community that's been overlooked kind of by Western science or colonized by Western science, we really need to adopt that same frame of mind. The understanding how community study, how to study communities through community-based participatory research is really important. This involves people from that community at all phases of the scientific process, so from the inception all the way down to conclusions. The other is things like phenomenological, so taking bracketing like we were just discussing, using different types of mixed methods as well, and all of it is going to basically start with the simple assumption that the scientist does not know, and that the scientist is going to enter into this community in collaboration with this community to ask this community what it is, what is recovery, how is it seen by the individuals who have that experience, what are the major benchmarks, and then out of that, what can we do as scientists to both define, understand, and measure this phenomena as it occurs out there. And allowing ultimately that anybody who identifies in recovery, that experience, allow it to speak for itself. And when we collect that type of information over the long haul and in aggregate, then we start to see certain patterns that will become reliable and objective in the scientific sense, and can be made objective in the scientific sense. Here's some references. My email's in the chat as well. So if you have any questions about literature, we don't have much of a chance to discuss the literature in particular, what might be helpful here. But if you do have questions in that regard, you can always reach out to me. I have more than enough studies and books which can assist.
Thank you so much, Dr. Brown, for your wonderful presentation. I will now open up the floor for some questions from our learning community here. Ralph?
Hello, thank you for this very interesting presentation. It's certainly something that I've never thought about, that addiction science was different from recovery science. I'm still kind of trying, I mean, I listen to the points and, you know, I understand sort of the words, the immediate meaning of the words, but trying to really put it into, try to get a deeper understanding of that. So basically what I've read is that addiction science is maybe more focused on prevention or early interventions of you know, healthcare, doctors, social workers, psychiatrists, psychologists, in an individual's life, and the recovery science being more focused on the journeys that the individuals make, and then also how to prevent relapse. But I've never really noticed this kind of distinction when people actually go to rehab or they follow up with a healthcare provider on their addiction. It just seems like it's all kind of together. So I guess my question is, I mean, is this more of a construct for research, or does it actually apply to practitioners? And if so, can you give me examples of, you know, what would a addiction specialist or scientist do when they're working with a patient? What would a recovery science person do? And then also, how would they, let's say you had a particular way of treating addiction, for example, opioid disorder, you might have Suboxone as a way of sort of a pharmacologic method of helping with addiction. How would the addiction specialist and recovery specialists evaluate whether it's a good treatment, an effective treatment or not?
That's really a great question. So I'm going to start with your last one first. And what I would say is that that's the answer to that's going to be based on the individual, right? So it's going to be based on what that individual wants, what they're hoping for, what they desire, what kind of outcome they're looking for. And I think we all kind of understand that from a place of clinical practice, and kind of honoring our clients' wishes and ethical practice. We don't necessarily see that as much in science or in policy. So policy is a really good example, because how many years have we been throwing solid science at policymakers, and yet, right, nothing's changed. And so, these things they should be separate, but they're also related. So I don't want to give the impression that recovery is so different than addiction that it should be. What I'm saying is that the inverse of addiction is not necessarily recovery from a scientific standpoint. So the reduction of certain pathologies or certain elements and symptoms of pathology does not necessarily equate to healing and growth. It's just the reduction of pathology. And so the reduction of pathology may open up the doors for healing and growth, but that they're not necessarily the same thing. Nor are they the same thing in the way we measure them. So one of the things I think about is the way they study depression. And basically you give someone a BDI, and then if they score lower on their BDI later, then something effective has happened. Well, depression has, there's a vast amount of things that are related to depression, why someone might be depressed. And, there are also things that occur in the recovery process from depression that are not on the BDI, that are not, we may talk about them in therapy, but they're not going to be on any sort of scientific metric. And so the idea that we don't necessarily have to measure recovery by the absence of pathology, but by the presence of growth and healing defined by the individual who's recovering themselves.
And I think if I may, Austin, to that same note, that as it's applied in a practical setting, RIT versus clinical training, at least in substance use disorder, the most severe of those being addiction, framework is different. Their approach to the individual. So while we may say that medical care and practitioners across throughout clinical medical systems are person-driven, do have autonomy and decision-making for clinical care, are not paternalistic, then that may be true as an exception, but largely it's not true in practice, both in how much stigma is prevalent in those healthcare systems, often the most highest. So I think it's the practical implication of that is everything Austin just said, but it's also to your point of what would they do differently? It would be the framework in which they approach a situation, both in how care is received, how the patient is involved in that care. And I think we see a marked difference from those that are trained in an addiction framework as opposed to a recovery-informed framework. So the practical application of RIT is not just theoretical research or science-based, it's also in service delivery for traditional addiction, medical, and clinical facets. It's certainly applicable to the recovery support services side of our provider continuum that's growing every day. So I do think there's fundamental and practical differences in addition to just measurement and inquiry that all stems from the underlying theory that guides their daily life. And I think the suggestion is here historically that recovery has been a primary endpoint, measured perhaps inappropriately in addiction, not a framework. This changes, I think, that relationship. And you see that in trained professionals and how they respond differently to people and provide that care.
Thank you. Marcy?
Thank you. My name is Marcy Doyle. I am from the University of New Hampshire. I am a nurse researcher here. I really appreciate the presentation. I thought it was excellent. We spend a lot of time thinking about the execution of services across clients in need, right? And so I wonder from you, Austin, when you think about the model we live under, the medical model and capitalism, how much does that influence our, research states and our need to kind of develop grand theories outside of these current states? And secondarily, how much does culture, do you feel like, play a role in American culture, play a role in sort of what recovery looks like here in the United States? Thank you.
Those are really good questions. Thank you. So one of the things that I've really noticed, probably in the last few years, has been this idea of efficacy, and efficacy becoming a stand-in for effectiveness. And efficacy under a capitalist system means that which produces the most punch for the least amount of dollars, or for the most amount of profit, right? And so efficacy becomes this, displaces this idea of effectiveness. So what's effective? Well, effective is, a long-term continuum of comprehensive care that lasts for years. And what systems are doing that? Well, none of them are, right? And it has to be pieced together, and you have to be certain privileged, of a certain privileged class to even be able to access these kinds of elements. But at the same time, the things that are effective, so I'll again rely on my own experience here. So what was it that really made the difference for me in recovery? Well, running a halfway house, being asked to manage a halfway house, and getting into a collegiate recovery program. So while I did receive treatment, that's not where I learned how to apply the things that I was trying to do in recovery in a way that was healing and helpful. Now, how many measures do we have for that? Right? How often do we measure it, and how often do we talk about it? Other research shows that employment is what accounts for the most variation in recovery stability. So having a job, right? And that's not generally considered a recovery metric, right? Although employment is sometimes brought up. So there are elements that are cut out because of capitalism that I think are really important to consider, because really what the capitalist system does is it says, well, what's the briefest intervention I can give someone that's going to give me the most evidence for billing, right? And so how am I going to bill for services? What's going to be accepted as effective practice that I can then bill for X amount of dollars an hour, or for X amount of dollars a pill, or whatever? And so that is fundamentally, when it comes to the experience of recovery, I mean, the richness of the experience of recovery, and then something like that, I mean, they're fundamentally different in a lot of ways. So not only are we missing the mark, but even when we hit the mark, we're reducing it down to such a meaningless construct of efficacy that it's not really doing much for us. And then culture, I think culture is huge. I think culture is huge both inside of the recovery community. I think that culture is the one component that we often leave out when we talk about recovery capital. But the filial relationships that people form in recovery with other people in recovery, both in ways that are related to recovery, but also ways that are like, hey, I don't have a job. Hey, I can get you a job, and I'll make sure you get an interview because I know you from recovery, and that's what we do for each other. So that kind of stuff is not even on the radar of scientific metrics. And so, there's the other aspect of culture that we have to talk about is we have to talk about the values and the ethics of those communities. And the values and the ethics of those communities are not necessarily something that we even consider in medicine, right? Or I think therapy is probably a little bit better at it than medicine per se, because they have to genuinely involve the individual. But culture is really enormous, and it involves, it's a multifaceted concept that really has to be brought into recovery science in a way that's meaningful, and has yet to quite get there.
Thank you so much. And thank you all for joining in this discussion. We will keep this discussion going in the chat, but in the interest of time, we will move on to the next part of our session. Karen, if you could please bring up the announcements from BVAL Texas. To claim your CME credit today, please text attend 10095268 to 844-502-1338. You must text by midnight tonight to receive the credit. Next slide. Do you have a research or evaluation related work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present a research or evaluation related work and receive feedback from our community of experts. There is no need to prepare a formal presentation. We will provide a case form to assist you with your case presentation. Please email us at cstat@utisca.edu. Next slide. The 2024 Texas Substance Use Symposium is officially open for registration. This free event will feature complimentary continuing education curricula, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. Texas is also open to sponsors and exhibitors. To learn more on how to become a sponsor exhibitor or to register today, please visit texas.org. Next slide. Join CSTAT and the Texas Health and Human Services for an 8-part webinar series to explore the intersection between behavioral health, substance use disorder, and COVID-19. Our inaugural session, Preparing for the Triple Threat, Rising Rates of RSV, COVID, and Flu, will be on Friday, February the 2nd. You can register for this free webinar session and upcoming webinars by visiting cstat.utisca.edu, and we will also drop the link in the chat. Next slide. And finally, please do join us for our next session on Wednesday, February 21st. And with that, we will move on with our case. Karen, if you could please bring up the case, and Robert, you can take it away.
Sure. Good afternoon again, everybody, or morning if you're somewhere else in the world. I don't know what time it is in Denmark, Austin, but really appreciate you being here because I'm assuming it's late.
It's just in the evening.
Well,
6-hour difference.
Gotcha. I'm glad it's not too late, and it's good to present with you again, and happy to fill in for this month's case presentation. And to set the stage for some of this, and I committed to all of my handlers today that I would not go over time like I'm wont to do, but we've been putting some legwork into PRIN. If you've been involved on some of these other echoes, you know that PRIN is the Peer Recovery Innovation Network. It's a research infrastructure project funded by the feds through NIH, specifically through the National Institute on Drug Abuse. We don't endorse the name, but it's NIDA. And that we're one of several funded projects to increase this kind of body of research. This echo is one of those. And there's a research agenda setting, as well as some pilot funding and some other elements going on, but it's not the only work that we're doing. So as we're thinking through really the next 2 months, or 2 years, not 2 months. I wish we could do all this in 2 months, but 2 years of a research agenda with the way that have been approaching research myself, specifically over the last couple of years, after doing a lot of the work and setting the framework that Austin just presented on, of what that could look like. So this is very early on, and this is one of the ways in which these case studies can be used if you're thinking about it, whether you're a provider, a researcher, or somewhere in between, is also in like the very early conception and planning phases. It's a good way to get feedback from a multi-stakeholder group, including people in recovery, if you don't identify that way, and bringing in some of that lived experience. So my hope today is to provide some of those initial thoughts as we're thinking about this work, provide some context, and then just get some, whether it's red flags or, hey, did you think of this? Or, hey, this would be cool from all of you. Also lower stakes, but much more at the early stage of the sausage making process of conducting research, at least in this way. So hopefully some of that context and baseline makes sense. So if you're reading what's on your screen, I'm going to paraphrase a little bit and provide a little more context. So building off what Austin just talked about, in 2019, 2020, and in addition to the research work we were doing and writing the grand theory around RIT and really putting out a whole lot of recovery science related research through this framework of both scientists as people in recovery, people who use drugs, people with lived experience, living experience, and trying to push forward that agenda of practical research using that recovery informed theory framework as it was defined so elegantly earlier. And one of those elements of that process was actually putting this into practice, right? Because research, especially on my community, so I identify as a person in recovery, and so this is part of the reason I do this work and bring that context along with my scientist hat. But like, we needed to build tools in support of this, because just doing research that then sits in an ivory tower or in a bookcase or in a locked door. Kim, I am not the host, but I will ask who's ever sharing to increase the size of the document. Somebody DM me, sorry, I'm just. But to that point, so if we conducting research in all of the ways Austin just talked about is the first step. Second step is, how do we actually put it into action, right? Because if we're just collecting research, especially if we're involving people with lived and living experience and wanting their expertise, not only should we pay them, but we should do something with the research. We should make it actionable, because otherwise, what's the point? Some may call that translational research or just a translational method in terms of dissemination. But it's really important to recovery, because if you're the ethics of data collection and engaging in science and co-creation with community means you need to give them something back. That's an exercise in both paying for their time, but something they can take to action. So we set out to build some tools heavily informed by our lived experiences as peer providers, peer organizations, people in recovery, along with several other RCOs. And we built a tool called an electronic recovery record. In disclosure, I serve as the CEO of it, just FYI. To build recovery support tools mirroring practice-based frameworks like electronic health records, but specifically for peer support providers that were built in such a way that the outcomes that were important to collect, the setup of practice models in terms of how people flow through formal and informal recovery support services, a framework to really collect what was important to both the workforce that we're most interested in, which in this case is peer recovery support service specialists, providers, recovery coaches, mentors, whatever language you may use, wherever you're calling in from, that actually was informed by them and collecting all those things that Adam or Austin just talked about, which is we shouldn't just be looking at endpoints that have been heavily informed by addiction science. Let's go talk to people and build them tools that they can actually collect what they want and get practice-based tools, which somewhat selfishly helps us do better research in the future. Because one of the things that we also, at least for me in the work that we were doing, learned early on, people don't like participating in research studies. Collecting data for the sake of research when we have practice-based data, we've got to find a way to do that. And there is a framework called a health services research framework, which essentially takes, whether that's things like claims data, electronic health record, or in this case, electronic recovery record data that's being captured in the form of service delivery. So there's no additional burden on peer staff, peer providers, or providers of other types. And more importantly, the people actually getting services, whether you clients, patients, participants, recoveries, etc. Can you go back up, please? I'll let you know when to go down. Thank you. So with that kind of context, this tool was released in 2019. We did a lot of focus groups out. There's some early users, including Cheryl and Alyssa from New Hampshire, that are still on it with their RCOs, which appreciate y'all's support in helping us make this tool that could collect this type of data that not only helps in the day-to-day and practice and helps quality assurance and brings people into the collaborative process of recovery support, but helps us look at some pushing the field forward using that administrative data, that practice-based data in studies moving forward. So that data exists. I'm actually going to skip down, don't go down yet, but the data set parameters just to provide you a framework of what we're talking about in some of this research and why it's, I said it launched in 2019. We're now in 2024. What have we been waiting on? We wanted to collect a very big data set. We wanted to ask some of these bigger empirical questions that are both important to people in recovery, important to RCOs and other peer organizations, important to policymakers and wherever you may exist in the continuum, likely important to you, because recovery science and even peer services as a part of the continuum of care is still so new. Our evidence base is sparse or just maybe premature at best. And this is how we've been thinking about it. So 1 through 5, what you'll see in here is these kind of study concepts, if you will, using this type of data amassed over 4 years, about 90,000 participants, just under 1 million types of engagements, which can vary from brief check-ins or telephonic recovery support to recovery planning sessions, harm reduction and overdose prevention sessions, referral sessions, all the things that peers do in RCO settings, if you could imagine. And it covers about 200 locations across the US. And his services provided by about 3,100 peer staff, peer supervisors, et cetera, to recoveries, those 90,000 people. So we have lots of data across the US in very different geographic regions with very different policies, with very different settings. But they're all currently, hey, we deliver peer services there. It's an RCO. Like, here's what we think we know. But is Appalachia the same as California? Is it the same as the Pacific Northwest? there's all sorts of questions. Who's it effective for? Formal versus informal? Like, we know very little about some of these processes and things that are getting more funding, things that have benefited my personal recovery and I support every day. So we wanted to look at answering some of those higher questions, at least from our level of importance over the next 2 years. So we did an original paper. There's several authors from this data set using just the New England corridor around predictors of recovery capital improvement, getting specific about trying to identify factors in the peer support process that are most helpful. We want to take that to a national sample. We also want to look at, if you look at point 2, those regional variations as an exploratory. Are these things different in different pockets of regions geographically? There's other types of communities too, I understand, but this one around regional variations to start looking at regional differences and effects. Also looking at 3, which I think is really in the spirit of Austin's presentation, the effect of services on outcomes that aren't just the bartender recovery capital, sure, important, but what people consistently tell us is more important than anything else, including substance use, mental health concerns, which is, do I have a job? Do I have transportation? Do I have healthcare? Do I actually have the things I care about? Because drug use and my mental health is actually really low on that list because I'm cold and I'm sleeping outside, for example, right? So this bucket of what we consider social determinants of recovery as something that not only can be self-evident, but measured as a primary endpoint, because it's what people in recovery told us matters more. And I'll asterisk here by saying, as you listen to both these presentations, even here, it's also not only dependent in that you should listen to people in recovery, but outcomes are individualized and have to be. And it's not just that the services are individualized. Outcome 1 could be really important to person 1 in the recovery community, but not matter to person 2, right? So there's a lot of different ways to think about this work. But that bucket of stuff that we're framing social determinants of recovery is looking at how do peer services affect some of those domains that exist in recovery capital, but also are much broader. Then looking at differences between telerecovery and in-person. Do those things differ? How so? That's still the great question after the ongoing COVID-19 pandemic. And then finally on here for us is RCOs are different. Service models are different. Some are informal, some are much more formal, between one-on-one services versus drop-in support. So getting a shower and going to a meeting versus doing a recovery plan, for example. And what is that relationship what people tend to choose what type of service? Is there any correlates there? Can we do anything with it? Can we better enhance service delivery and make it more compelling across the board? So also an exploratory, because we don't know what we don't know. That being said, if you will scroll down now, so this is really for everybody. A little further, please. I'm going to go right to the key questions and then also ask my helper person also put this in the chat while I explain what I'm hoping to get. So general thoughts certainly welcome, right? As I said, this is very early on in this process of thinking through what we want to do, what we're looking at. It's a nice thing about administrative research too. We can define a priori hypotheses. We can suggest what we're going to look for. We can also do exploratory analysis because the data is already collected. So we can look at it in lots of different ways. So there's no wrong answers here. So certainly any general comments, but I also did put together some key questions of how I thought about it, depending on the role that you exist within life, at least primarily, because you all have many different hats, many different roles like I do. But for researchers, what type of primary endpoints, what types of outcomes would you prioritize? What are you most interested in? And whatever experience you bring to the table, it says, I care about this. Hey, is it in the data? Hey, it should be. Hey, analyze this. For those of you that may be methodologically inclined in terms of data integrity and cleanup and things that we should be considering for large scale, because this is the largest recovery data set ever amassed, how should it be prepped? How should it be clean? Anything we should be thinking about from a method standpoint. If you're a peer or provider or a peer organization, what are you most interested in actually knowing about the services that you're doing every day? What outcomes are most important to you, your organizations, and perhaps most importantly, the communities that you're serving that you haven't heard about, or just that's top of mind and you really wish, like, I want to know if this works. Like, who are we impacting and affecting? Because what's happening on the ground matters perhaps most in terms of answering. And if we happen to be a policymaker that I don't know if there's any on today, is what type of data and on the role and impact of these services that you're now funding perhaps more than ever or reimbursing for could help you craft better and more inclusive behavioral healthcare policy, whether that's local, state, or feds. So some key questions to get you started, depending on your role, also open to just general commentary to help us be thinking about this. Thanks.
Thank you so much, Robert. And we'll keep this for a minute here so that folks can ask questions and share comments. So here's a question from Megan. How many had access to mental MH therapy?
So it's an interesting question, right? What I'm going to tell you is, so access is different than actually utilized. So depending on which way you're trying to go at it, I don't know in a practical setting how many organizations, at least in this data, are tracking availability of, but essentially did not engage with. What is in that data set is how many were engaging with some form of mental health therapy or treatment at onset, so intake into peer services, how that trajected over time, looking longitudinally from their service episodes, or just one episode if they only engaged once, and then also how many engaged in that process. So how many weren't engaged at baseline but started at some point. So depending on how you conceptualize or operationalize access, it may be in there, but I think that's how, at least at the provider level, we've been talking about it. But if you otherwise meant access, so who actually could have gotten it if they wanted to, certainly take the clarification. I think it's a good point and certainly an interesting query.
Yeah, I was just thinking, just from my experience working in a place where we're trying to help folks in recovery, and how often mental health, whether it's psychiatry or psychology or even a clinical social worker, helping with some sort of therapy is super needed. And you've got such a great data bank, and maybe comparing, it's hard. I don't like using the word success because that's kind of hard to gauge. More like maybe the length that they're in recovery services, rather than saying success, and how that compares to the ones who maybe were in medication versus the ones who had some sort of mental health therapy versus the ones who are engaging with peers often, and just kind of seeing how they all line up, or what the big need is. But that's awesome that you've collected all that. Like, I'm super interested to see where you go with it.
No, thank you for that. And I think that's important takeaways. I think overall too, it comes back to is certainly how we define it too, right? And I think to your point of success versus not, there's things that we define and it's either true or not true, right? Because length of engagement as an engagement outcome may or may not be indicative of success. Like really what success is if I ask this person, do you perceive and were you successful, and do you feel like your recovery is better today as you define it than it was 6 months ago? Like that's the only really successful income. The rest of it is descriptive of something that we have identified or defined, right? I have still not figured out how to get that into data collection to really get to that point, because it's different. The outcome is different for every individual because it's unique to the individual, since success is different. We got some proxy of that maybe by primary recovery pathway, right? But it's not quite the same thing, even though that's reflexive and dynamic. But all good points. Thank you.
Thank you. And we have a question from Dr. Potter. I would love to see trajectories and course and realize that it's broad. Do you have multi-month data for the same individual?
So, it's reflective of practice, right? And I think one of the hallmarks of peer recovery support services as delivered in a service model that is recovery informed, because it's the only way it really should be or can be in most part, at least the service settings we're talking about, is everything is different, right? Could you normalize to an average trajectory? Because some people will engage for 2 years, some people for 6 months, some for 90 days, and everybody's intensity will be different, right? Because they really get to choose what these services look like. At least from this data set, we're not talking about coercive care, people mandated. Like these are traditional RCOs getting peer services, so the person defines it. And I think that goes back, I don't know enough today, and how do we normalize those trajectories, because it's not going to be standard. And I'm sure there's ways to do it, which I think we will have to, but I think it's the trick with admin data is because everything's not as clean as it with new data collection, right? Where you had a proposal and study design.
Yeah, I'm going to be really brief because I don't want to, but I do think that there's some ways that you might be able to look at multi-level modeling because of the size of the data, and be able to get some respect for the individual trajectories along with this broader piece. And I don't mean to oppose a course of disease language, which is sort of what I did, and I recognize that. But I think it's really interesting to understand what happens to people when they engage in peer recovery support, how they go in and out of the system, if they do, how they engage, how they drop off, what they ask for when, and things. So I think it's a really, really unique opportunity, Robert. Congratulations on that. I know that was a big lift.
Sure, yeah, and I think those are all, one, I heard everybody gasp and say Robert needs a biostatistician from Jen. for some MLM work that he's not proficient in. But I think it's also like there's ways to do that, even if those are clinical undertones, and right, in terms of how people oscillate and navigate through a system and access additional services, while traditionally payer focused or clinical or medical focused, like I think there's also value from the recovery informed perspective that asks those questions, because most frameworks would say any adjudication based on claims and accessing care in what we deem inappropriate, whether it's because of cost or because of traditional recurrence framework and failure, can be framed differently while still tracking in a recovery informed way, which is people access what they needed. They weren't provided the level of service that they, right? It's not a failure. So I think it can be done in recovery research as long as the framing of the results is done in a recovery informed way. And I think to the question before, right, none of this precludes bringing in addiction scientists to do this work. Pathology has a role to play here. It's just not the preeminent focal point anymore, at least in this body of type of work.
And we'll just take a couple more questions. Ralph would like to know, other than court order treatment, how do patients find their way into recovery therapy and what keeps them in therapy?
I'm looking, I think those are site specific, right? It's some of these questions, like people's trajectory into our continuum of care and how they get to where they're going is different for every RCO, right? Whether it's self-referral, whether it's non-coercive referrals from a standard component of the ROSC, which may be a carceral system, which may be a housing provider, which may be social services providers, which may be clinical providers. But I think it is somewhat different in people's trajectories of how they get somewhere in terms of the apex point of how they may define starting their recovery process and engaging with it. Some of those explorations still have to be done. And I think it's one of those ways in which to look at this and to just humbly admit as a field, we don't know what we don't know, which is a whole lot of things.
And finally, this question from Chandra is, how many organizations are regularly serving peers who identify as deaf, hard of hearing, deaf, blind, and require accommodations? And how are they funding the accommodations they provide?
Yeah, so it's assistance with daily accommodations is a data point. If collected, again, this is practice-based data. It's up to sites what they do and don't collect. So it is collected both for hearing, deaf, and blind, different accommodations for physical abilities. There's all of that is within there. That in terms of the cleanliness of the data and what those accommodations are, I don't know the extent of what's in there other than it can be and is collected. In terms of the latter parts, I think those are follow-ups based on whatever those preliminary findings are, which is an empirical, study with those sites themselves of how they handle these, because I expect you will see a wide variability in a lot of different things as it comes to processes and policies, whether ADA or different abilities or otherwise, because there's not really, maybe there's some standards, there's some accepted best practices, but systematic replication of a service model being the same, I think you get the same benefits of community that we've talked about also manifests here, which means everything is so responsive to their community. It's delivered slightly differently. There are different stages of development, their funding levels. Do they have over 50 employees and some of this stuff actually triggers? Like there's lots of frameworks into that type of questioning that would probably not be answered as fully from this data set, but I think as we mature as a field, those are going to be some big questions. Who's getting peer services and equitable access? We're starting to see more done on race and ethnicity, gender identity, sexual orientation, et cetera. But I think as you look at abilities and physical and otherwise, IDD, et cetera, it's still very nascent. And we don't know, even less probably in that sector of the field.
Thank you. And thank you, everyone. This was a wonderful discussion. And in the interest of time, we do have to wrap up. Robert, if you could please give us a quick summary of today's session. I know this has been amazing.
Just of the case. So overall, great day. Your case presenter was amazing. And so was your didactic, is what I really was my takeaway. But I think some of the bigger takeaways is that we're amassing data in a recovery informed way, and we've never had access to it. What comes next, what research is being done, and how it's output and activated is going to be critical. So you saw from here that, lots of feedback of things that people will want to collect. It's different for every sector. You can imagine why it's hard to put together a recovery, not only technology, but research, study, and engage in this work. It's a lot extra. We still have a lot of work to do, including exploring things like peer services for underseen and underserved populations by our current continuum. And if you haven't yet, read the Recovery Informed Theory papers and change your whole perspective.
Thank you. And we will download this chat, Robert, to help you with the feedback from the community here. And thank you all again for joining today's session. As a reminder to earn CME credits, please complete the session in the chat. If you would like to present a case, please email BVAL-Texas. We do look forward to seeing you at our next session on Wednesday, February 21st at 12 noon Central. Thank you and have a wonderful rest of your day.